I invite the next speaker, Hisham Hamdy. He did his residency at Qasr Al-Aini Hospital, Cairo University. He has particular interest in vitiligo and an advocate for early aggressive therapy. Now a practicing dermatologist at Cairo University Student Hospital. Over to you.
Good morning, and thank you for the kind introduction. I would also like to express my gratitude for the opportunity to present my work today, titled Early Localized Vitiligo is Not Early, a Tissue-Resident Memory T-Cell Study. Now, to start off, as we all know, non-segmental vitiligo exhibits complex interactions between genetic and environmental factors, ultimately contributing to one's susceptibility to develop the disease. Furthermore, the presence of tissue-resident memory T-cells in lesional skin is now known, and it suggests their role as active players in disease maintenance and recurrence of the lesions. The aim of our work was to detect the presence and diversity of these tissue-resident memory T-cells in short-duration and long-duration cases of localized NSV and its possible reflection on disease progression. Ours was an observational comparative study where we sampled 14 short-duration cases of localized non-segmental vitiligo, that's equal to or less than 6 months, and 14 long-duration cases, that's more than 6 months, and 18 control subjects. We included all patients of localized NSV of all genders, but we excluded patients less than 14 years, pregnant patients, patients with other autoimmune conditions, and those who received any type within the last 3 years, and of course, generalized or segmental vitiligo. All patients in the study were subjected to a full history taking, assessment by VASI and VIDA scores, punch biopsies from perilesional and unlesional skin, and a skin sample from controls as well, and these biopsies were assessed by immunofluorescence for CD8 and CD69 as markers for the TRM cells. What we found was a significantly higher expression of CD8 and CD69 cells in perilesional and non-lesional sections of cases of localized NSV compared to controls, and this also correlated positively with disease activity. In short-duration cases, both CD8 and CD69 showed higher expression in cases than in controls, while in long-duration cases, only the CD69 was higher. Moreover, upon comparing short-duration and long-duration cases, the VIDA score was significantly higher among short-duration cases. Moreover, CD8 expression in total skin of the non-lesional sections was significantly higher among short-duration cases compared to control cases, compared to long-duration cases, while CD69 expression in dermal and total skin layers of perilesional sections was significantly higher among short-duration than in long-duration cases. Double staining did not yield any significant results, only positive in 4 out of the 28 cases, but it's worth mentioning that 3 of those 4 were from the long-duration case group. Therefore, we found that in our cases of localized NSV, perilesional sections of both short and long-duration case groups showed significantly higher expression of CD69 compared to controls. The expression was also significantly higher in perilesional sections than in non-lesional sections. CD69 expression was significantly higher among short-duration cases than in long-duration cases. This could be due to the significantly higher VIDA score, and this is further confirmed by the significant correlation we found between CD69 cells and activity, whether in short and long-duration cases. So a patient in activity, even with disease duration less than 6 months, has a higher expression of both markers and thus a higher risk of overtime accumulation of melanocyte-specific TRM cells, and so the recurrence of the disease. This is confirmed by the presence of significantly higher expression of CD69 in non-lesional sections of long-duration cases. Regarding the significantly higher expression of CD8 in both case groups compared to controls, this concluded that perilesional skin from vitiligo patients was infiltrated by CD8 T cells and was noted in comparison to non-lesional skin. Regarding the significantly higher expression of CD8 T cells in non-lesional sections of short duration compared to long duration cases, which were similar to controls, this is a possible determining factor in the progression of the disease course. However, we could not detect a significant correlation between disease duration and CD8 expression in non-lesional skin. The significant findings we found in the non-lesional compartment in cases of localized NSV raise the concept of considering vitiligo as a systemic disease. Now, most guidelines consider systemic treatment only in generalized progressive disease. A delay in halting the immune attack may give the chance for further disease progression, as well as establishment of the TRM population predisposing to future relapses. Targeting the ongoing autoimmune process in vitiligo as soon as it starts might be a solution to stopping vitiligo or curing it. Interesting correlations we found were the long duration cases, CD8 expression in non-lesional sections correlated with VASI score. So the larger the area of involved skin, the higher the risk of developing more lesions. And additionally, negative correlation was found between expression of CD8 and CD69 and the age of the patient in both case groups, meaning that the older the age, the lower the immune activity. In conclusion, localized NSV cases of short duration show higher expression of CD8 and CD69 T cells in both perilesional and non-lesional skin. These could constitute a TRM population capable of inducing autoimmune memory, contributing to further spread and recurrence of the disease. Our take-home message is the emergence of such difference in the expression patterns of these markers in the early months of localized NSV indicates that even with a single vitiligo lesion, memory T cells are already there, widely distributed in non-lesional skin waiting to unexpectedly form new lesions, further indicating that vitiligo is a generalized disease from the start. Early initiation of systemic treatment could be the key to avoiding recurrence. Thank you.
Thank you for that interesting talk. Any questions?
Yes, التفات.
Basically, thank you, surface area. Did you find any correlation, or have you thought about any correlation? Because again, to Dr. Pandia's point, the Vita score, we're not sure if it's the best measure of stability. But if a change in body surface area correlates to stability, then you should have a shift in your CD69 and the CD8 cells. So do you have any analysis looking at the VASI score over time and the density or the measure of these inflammatory markers?
No, we didn't really find correlations with the VASI score over time. The correlations were related mainly to the Vita score, but as the professor said, maybe it's inaccurate. Patients 50-50, I guess.
So, thank you very much for your talk.
Thank you.
It seems to me that makes sense what you presented, because we can expect to have infiltration of the melanocytes, of the lymphocytes, any type of retinal memory T cells or CD8, when there is the release of antigens towards these cells are prone to. So if we have melanocytes on the skin that probably are capable to release factors capable to attract the lymphocytes, or in any case the immune response related cells, we can find the cells. When is the pigmented area, since we have not the melanocyte that is the target of these activated cells, the number of the cells significantly decrease because there is no any specific chemoattractive factors. That seems to me make a sense, even with the data that Professor Pandia told before, that together with the journalists have demonstrated the presence of inflammatory molecules even in pigmented skin of vitiligo patients. So if we have the antigens, and there is the possibility, according to our data, that these melanocytes release DAMPs, these molecules are capable to recruit inflammatory cells and specific, targeted immune cells, T cells, towards there is the antigen. Where melanocytes disappear, there is no reason why the cells remain there, or why CD8 cells would be there. I believe that probably make very sense of what you are presented. So this is reasonable to start with a systemic therapy, even with the appearance of the first spots of the vitiligo, because certainly around there are some other immune cells ready to start again to spread the disease. Thank you.
Thank you.
Maybe I have one quick question, please. Do you... Oh, sorry, Amit. May I? I fully agree that there is probably a window of opportunity at the beginning of the vitiligo. I was rather surprised that you found TRMs, and especially more TRMs at the beginning, or at least roughly the same when the vitiligo is starting as compared to long duration. For example, in psoriasis, it's been shown that there is an accumulation with time. So how do you explain this discrepancy?
We can't. We expect the the markers to be there, maybe we need more markers specific to the tissue-resident memory T cells like CD49A and CD103 pending further research, but we can't really explain it at this point, that discrepancy.
Yeah, I had the similar question. The resident memory T cells are there after treatment, even after the lesion goes away. And that's the reason it comes back in the same spot later on. So I'm having difficulty understanding how the resident memory T cells, like you're stating that you should treat early to get rid of the resident memory T cells. I thought that the main point of treating early is to get rid of the effector CD8 positive T cells. And so I was a little surprised that the resident memory T cells were involved so early on. And I'm not sure if they're going to go away. This is one of the reasons they're doing the IL-15 studies, is to try to get rid of the resident memory T cells, because the JAKs do not get rid of those cells.
Thank you.
Well, actually, when we designed this study, we thought that we are going to find no resident memory T cells in the non-lesional skin of the early cases. And it was and this was documenting that my hope that we can catch the disease at its start, because before developing resident memory T cells in other sites. But actually what Mauro is saying, that it seems that with the first cell is exposing the antigen, then the resident memory T cells are present everywhere, and this was proved by the results. Yeah. Thank you.
Thank you.
Thank you very much.